Okay, welcome back everyone. We are here in the Cardiology Webinar, Day 1. Our next speaker for today's session is Dr. Mark Connaughton. Dr. Mark Connaughton qualified in medicine after training in Oxford and London. He completed an MD by research at Ryan Institute at St. Thomas Hospital, London in 1996, subsequently completing advanced training in cardiology. He has worked since 2000 as an invasive cardiologist with interests including the management of acute coronary syndromes and infective endocarditis. The title of his talk today is Optimizing Management of Infective Endocarditis is a non-surgical in a non-surgical center. Hello, Dr. Connaughton.
Good morning.
Please.
Good morning, and I'm very grateful to the organisers for the invitation and the opportunity to speak to you all today. As stated, I'm going to talk about optimizing the treatment of endocarditis in a non-surgical centre. Just give me 1 second. So what I'm not going to do is give you a comprehensive guide to all aspects of the management of endocarditis. I've got 40 minutes. I don't think you'd expect me to be able to do that. But what I will be telling you reflects at least 20 years of experience of treating patients in a non-surgical centre. I appreciate that many of you will work in smaller institutions where you don't have cardiac surgery on site. And what I'm hoping to do is to offer some insights into how we do things here. Most of the information about endocarditis of necessity does not come from randomized controlled trials. It comes from observational studies, it comes from registries, and subsequently from expert recommendations. So while I don't want to put my hand up and say I'm an expert compared to some people, we do have long experience and we do have a degree of success, which I hope I can pass on. So I work at St. Mary's Hospital on the Isle of Wight. The Isle of Wight is a fairly large island off the south coast of England, one of the largest islands surrounding the mainland of Great Britain. We have 246 beds. We only have 2 consultant cardiologists to service that. And we have a resident population of 140,000. That's small by standards in the United Kingdom. More typically, a health district will have around 250,000 patients, but we do have 3 million visitors to the Isle of Wight each year. We're a very popular tourist region, and so our overall workload is comparable to that of an average-sized district hospital of around 250,000 catchment area, so we're not far off that. So what do we have and what don't we have on site, just to give you an idea and perhaps a comparison with your own institution or what your own health economy provides. We have 2 cardiologists. We have state-of-the-art transthoracic echocardiography and experienced sonographers. Each of the consultants performs transesophageal echocardiography. We have standard CT scanning, we have standard MR scanning, and we have experienced microbiology consultants. What we don't have is a 24-hour or 7-day cardiology service. So for 5 days of the week and out of hours, if there is an emergency, if a patient deteriorates, then we do depend on acute medicine or general medical colleagues to see the patient and to make the decisions. So there has to be a lot of communication with colleagues when we have someone who may deteriorate and may require a potentially difficult transfer out of ours to a surgical centre. We have a difficult stretch of water in the way between ourselves and the mainland, and although the physical distance is short, getting a sick patient across there to a cardiac surgical centre will typically take 2 to 4 hours. We don't have cardiac surgery on site. That's the whole point of this talk. We don't have renal medicine on site, although we do have renal physicians who visit 2 or 3 days a week and will provide advice. We don't have specialist cardiac CT or cardiac MRI, and we don't have the more advanced imaging modalities such as nuclear imaging or positron emission tomography CT. So with regards specifically to the clinical picture of endocarditis, there are 2 big registries published this century, and it will be clear from these that the epidemiology of the condition overall is changing, but the mortality of the condition overall remains high, and most cardiologists would argue unacceptably high. So these 2 big registries, both international, both done from a lot of hospitals, so they should reflect real world practice to a large extent. Some of you may be surprised that the incidence of embolic phenomena in endocarditis is as high as quoted, but somewhere between 1 in 4 and 1 in 5 patients will experience a clinically relevant embolus at some point in the infectious period, often early in the infectious period. The pattern of which valve is infected has certainly changed, so that more devices are implanted these days, and they've become a focus for infection, and there are more infections on prosthetic valves, probably reflecting the fact that the indications for valve replacement have widened. The population continues to become older, but surgeons will take on more elderly and more frail people. And so consequently, the percentage of native valve endocarditis has gone down from around 70% to under 60%. Surgery is indicated in a large proportion of patients, well over 2/3, but it's performed in fewer, and that will become important in terms of the outcome, as will be stated later. And the in-hospital mortality really hasn't changed over the last generation. So around 1 in 6 patients will not survive the episode. The complications of the condition are very significant. And so again, these do seem to have changed in terms of their incidence. So heart failure is now seen in rather fewer patients, perhaps reflecting more awareness of this and better care for the heart failure and perhaps earlier referral for surgery. Embolization is at least as common. There weren't direct comparators between the 2 registries, but 2 in 5 to 1 in 3 patients will experience an embolus, and 1 in 6 of these will have a stroke, which is usually a devastating complication. Some form of abscess formation seen in 14 or 15% of people, and almost 1 in 5 will develop at least transient renal failure. The outcomes after surgery vary rather widely depending on which centre you look at. There'll obviously be some selection bias here, but in a major US centre, they quoted very favourable rates of mortality. So one suspects these patients were somewhat pre-selected to a degree. The European registry, looking at a much higher number of patients across multiple institutions, showed what to most cardiologists would be a more realistic mortality rate of around 17% overall. The worst mortality is in patients where surgery, according to the European guidelines at least, is indicated but not performed, so that perhaps surgeons back off because of other comorbidities, even when in terms of the endocarditis, surgery would be indicated, and those patients, perhaps unsurprisingly, do rather badly, with approaching 1 in 3 being dead within 1 month of diagnosis. Now, the European guidelines, which are the ones we tend to base our practice on and expand from there, does strongly support management of patients with endocarditis by a specialist team in what it calls a reference centre. And this is all very well, but we are physically removed from anything one could call a reference centre. And most of our patients, not least because we live on an island, don't want to be away from home for anything up to 6 or more weeks. So for an extended period of antibiotic therapy or for surgery. The other issue with teams is, while the idea sounds good, one isn't always sure who's involved and whether that team is fixed, or is it just put together on the relatively infrequent occasions when endocarditis is diagnosed, which I suspect is the case most of the time. And in a team, it becomes more difficult to point out who's ultimately responsible for the patient. Certainly in the United Kingdom, a single consultant is always in charge of one patient, which makes the chain of command and the decision-making straightforward in terms of defining responsibility. When that responsibility is handed on to a team, it becomes much more difficult to say who's calling the shots and who's making the decision. In practice, in a non-surgical centre such as ours, therefore, the team is likely to be virtual. It's spread out, it's in communication via telephone or email, and you therefore need good rapport up front with colleagues such as cardiac surgeons, microbiologists, maxillofacial surgeons to ensure dental treatment and dental hygiene, and with general physician colleagues, not least because of the out-of-hours commitment. So what I'd submit to you is that the role of the surgical centre and the standard of care it should be providing is first to recognise higher risk patients and transfer those patients who will clearly benefit from assessment and likely surgery. They should be transferred at an early stage to a surgical centre, which would recognise the recommendation from the European Society. And for those patients that you hang on to, you achieve outcomes in them which are equivalent to those in surgical centres for the ones you've selected. As a summary of the management plan, I'd like to break this down into 3 very straightforward phases. The first would be diagnosis. The second would be to make an estimate of the individual's risk and to treat those who you decide are of lower risk and to monitor their progress. Endocarditis is a dynamic illness. It can get worse, it can get better. So the monitoring is just as important as the treatment. Now, in terms of the diagnosis, I would argue that you should base this firmly on the Duke criteria. The Duke criteria have been around now for some 30 years, but they've not yet been superseded. In real-world patients, this means 2 things. The first is demonstration of relevant infection, and the second is the demonstration of endocardial involvement. So the term infective endocarditis really gives you the answer about how to diagnose it. You diagnose the infection, you diagnose that the endocardium is involved. And in real-world terms, what this means is you need information from blood cultures because pathological or operative information will usually be too late. And you need information from imaging, but this is almost always going to be from echocardiography. The clinical aspects of diagnosis are important. No single clinical criterion is diagnostic, and no single laboratory test is diagnostic. So diagnosing endocarditis can be complex and often demands some experience. There are some historical myths about the clinical aspects of endocarditis, and they're almost all wrong. The fever is seen in up to 90% of patients and is an important sign, but the pattern of fever is irrelevant. So when people talk about swinging fevers or fevers occurring every other day or every 3 days, this is irrelevant to the diagnosis. A heart murmur will be heard in up to 85%, but the changing murmur, again, is largely irrelevant. Emboli are surprisingly common. We've seen that in the registries, anything up to 30, even 40% of people. And so if you have the combination of fever plus an embolus in a patient that you don't otherwise have a good diagnosis on, this can be a useful clue. Some of the stigmata of endocarditis can be regarded as purely historical and not useful. My favorite among these is splinter hemorrhages, which are so common, particularly in people who use their hands a lot. And this can be anything from recreational gardeners to manual workers. These are useless diagnostically for all practical purposes. Imaging we do almost exclusively with echocardiography, and the diagnostic accuracy for echo is high. So transesophageal echo remains the best modality, but is not suitable in everyone. And although it's not strictly invasive, demands more logistics, but the sensitivity, especially if there's prosthetic material around, is very high indeed, approaching 100%. But both transthoracic and transesophageal echo do show specificities if they see typical oscillating masses of at least 90%. CT scanning, even though we don't have specific cardiac CT scanners or cardiac radiologists, can nonetheless be useful. You can look for abscesses, you can look for fistulae, and this may be more useful, particularly if there's a large amount of prosthetic material. We are now seeing individuals come through who have valve-in-valve percutaneous TAVIs, percutaneous aortic valve replacements, so that there can be a lot of prosthetic material around, and detecting abscesses or vegetations in this setting can be difficult with echo alone. And again, planning surgery, it may be useful for a cardiac surgeon to have some prior imaging of the aortic valve and the aortic root to help them plan. Are there predictors of mortality early on? Well, yes, there are. So the comorbidities are important, and these can to some extent be quantified with things such as the Charlson Comorbidity Index. High creatinines, so if there's already a degree of renal failure or heart failure, these are poor predictors. Very large vegetations with a nominal cutoff of over 10 millimeters in maximum diameter. Cerebral complications such as stroke or transient ischemic attack or cerebral abscess are all very poor prognostic indicators. And an important one is the failure to undertake surgery when indicated. So if you do work at a surgical center, I'm sure you'll be familiar with discussions with surgeons when they're reluctant to do something, but almost automatically this worsens the prognosis of the patient. In a little more detail, I'd like to go on about this because it's such an important part of the early decision making, but I'd want to split things up into 4 factors. Patient factors, cardiac and non-cardiac complications of the infection, the microorganism itself, and the echo findings. If there are adverse features in 3 out of 4 of these categories, the chance of proceeding to surgery or to death is approximately 80%. So these are the high-risk patients. These are the ones you should not be keeping in a non-surgical center if there's a choice to transfer them. And this is the sort of logic which has served us pretty well in deciding who and when to transfer patients. I'd like to go into these in a little more detail. So patient factors, most of these will not surprise you, but more advanced age, frailty, the presence of a prosthetic valve or a cardiac device, so foci for the organisms to infect, presence of diabetes or significant other problems with mounting an immune response. So external immune suppression, the presence of renal disease or significant pulmonary disease. The complications of the endocarditis infection itself, if it's already causing heart failure or renal failure, if it's caused a stroke or brain hemorrhage or septic shock, again, these are going to be much sicker patients. And if they're going to survive, they're going to need to be managed in a larger centre with cardiac surgery on site. Microorganisms, most endocarditis now is caused by gram-positive organisms, and Staph aureus is creeping to the top of the list and is often very troublesome. But gram-negative bacilli are often also very troublesome and demand long courses of antibiotics to eradicate them, even after surgery. And fungal endocarditis, again, has a very high mortality. If one turns to imaging, but particularly echo, the predictors of poorer outcomes include a large vegetation, complications around the annulus of a prosthetic or native valve, such as dehiscence or abscess formation, a severe regurgitant valve lesion, which will almost certainly predict heart failure, low left ventricular ejection fraction, because then the heart's suffering, the presence of pulmonary arterial hypertension, and evidence of elevated diastolic pressures. Again, this suggests the left ventricle is not coping well. Fungal endocarditis gets a special mention. The mortality is likely to approach or to exceed 50%. And for successful treatment, it's almost certain to require surgery. The commonest fungal infection that's seen, I think, is Candida, which is a very destructive, progressive organism. So there's a high chance of abscess formation, and difficult reconstructive surgery is likely to be required. Almost all of these patients will require transfer to a surgical centre if they're to survive. If one doesn't grow anything on culture, and remember, I was saying earlier that blood cultures are one of the foundations of diagnosis, then you need to involve your microbiology colleagues at an early stage for diagnosis. So I'd suggest you go over the history, go over the clinical findings, and then perform serology dependent on what's out there, what your microbiologists advise. But this will be looking for organisms such as Coxiella, Bartonella, Legionella. In an agricultural setting, perhaps Brucella and Aspergillus, so much rarer organisms. There may be some clues from public health as to what may be involved. If these are positive, then one can do specific polymerase chain reactions to confirm the diagnoses. If they're not, then one can do a slightly wider sweep just of PCR on blood. And there you're looking for gram-positive organisms, but also gram-negatives and the fungi. And if none of those turn up on PCR rather than just culture, then one's looking for proper culture-negative endocarditis. So in certain autoimmune conditions, so one's looking for anti-nuclear antibodies, antiphospholipid antibodies, anti-pork antibodies, and involving rheumatology colleagues to see if some sort of autoimmune or multi-system disorder may be relevant. I'd like to summarize the clinical pathway because I think this may help to inform people as to what we do, and you may be able to take something from this. But once we've confirmed the diagnosis, which I think is the first step, plan things with microbiology colleagues, particularly if it's likely to be a difficult diagnosis or the antibiotic therapy is going to be extended. Step 2 would be to look at the risk. And if there are fewer than 3 out of 4 of the indicators of high risk that we discussed earlier, then we can start guided treatment at the local centre. If there are at least 3 out of 4, you've defined a high-risk patient, and the patient should be transferred at that point to a surgical centre. Third, if you start treatment and there's good progression with clinical monitoring, then you can complete the therapy and allow the patient out of hospital once the treatment has been completed. If they're not progressing well, then again, these patients need transferring. And post-discharge, if there's good progress, all well and good. One can monitor them as an outpatient intermittently. If they're not making good progress, again, they should be sent back to a surgical centre. So the immediate care, and forgive me if I'm going to repeat myself to a degree, first confirm the diagnosis using the Duke criteria. This involves both microbiological and echocardiographic or other imaging data. You're going to need secure venous access. We often ask anaesthetic colleagues or critical care colleagues to place a long line, so a peripheral central line. This allows blood sampling and allows easy administration of intravenous antibiotics without multiple venous punctures with short intravenous cannulae. The standard for replacing those in the United Kingdom now is around every 2 to 3 days. So a long line can stay there for the duration of treatment, even if that's many weeks. Virtually all patients will need a maxillofacial or general dental assessment and treatment if required, and then look at the risk and determine if there's an indication for surgery or for transfer. Lastly, I'd emphasize it's important to discuss things properly with the patient. This will be a devastating diagnosis for them. They may not survive. They may need extensive surgery. They're likely to be in hospital for an extended course of treatment, and psychologically this can be very demanding. So they need a proper sit-down talk, counselling as to what they can expect, not least in terms of support from family and friends. And particularly in the COVID era, we've had to limit visitors from outside, and this has been psychologically very demanding for our patients. Clinical assessment needs to occur each and every day, so we're reliant on general medical colleagues and acute medical colleagues out of hours for this, because we're not present 7 days a week. We take blood generally at least twice a week, looking at basic things such as blood chemistry, liver function, a blood count to see what's happening to the white count and the hemoglobin, and inflammatory markers. We generally favour C-reactive protein. A lot of antibiotic regimens will include an antibiotic where the levels need measuring. These can include things like vancomycin or gentamicin. Transthoracic echocardiograms, assuming the images are good enough, we will do at least once a week, and we'll look for evidence of conduction system disease with a 12-lead ECG and urinalysis as a screen for any renal involvement over and above the blood tests. As we've mentioned more than once, the embolic risk is significant, and it's important to think and look for these clinically. The indications for surgery during treatment, during the monitoring phase, are several. Again, we've mentioned these to some extent, but the ones I'd highlight would be heart failure, failure to control the infection, however one defines that. That can be on clinical grounds. It can be failure for the fever to resolve, or for the inflammatory markers to stay high. If there are difficult to treat organisms, and I'd certainly include fungi in that, but also some gram-negatives such as Pseudomonas or a vancomycin-resistant Enterococcus, I would suggest these patients are transferred to a surgical centre. And then for very large emboli, where there's a very large vegetations, where there's a high risk of embolus, again, I'd consider transferring those for assessment for surgery. It's particularly difficult to negotiate surgery if someone's already had a stroke, particularly if they've suffered a degree of disability from the stroke. And really, this is a situation where prevention is so much better than cure. Assuming one gets to the end of a treatment course, what about follow-up? Well, the European guidelines again say this should be done by the Endocarditis Team or a heart valve clinic specialist. Now, there's no controlled trials to guide that sort of practice. This is expert recommendation, and local circumstances, particularly in your own health economy, may vary hugely. What I'd suggest to you is that follow-up has a number of roles. You have to determine what the new baseline cardiac and valve function is. And importantly, you want to detect or exclude reinfection. And one thing to determine is whether surgery is likely to be required downstream because of either of these factors. In practice, the need for this is comparatively low. The European Society quotes a reference range of around 3 to 8% for patients proceeding to surgery after their antibiotic treatment is likely to be completed. But the best guide will be comparing yourself to local series and building up your own expertise. Recurrent infection, thankfully, is pretty rare, somewhere between 2 and 6%. And one should distinguish between relapse, where the same organism is involved, and reinfection, where a different organism is involved. Relapse suggests that there's been incomplete treatment, perhaps with a resistant organism, such as fungi, Legionella, Mycoplasma, Coxiella, all of which are comparatively rare causes. Now, most of our patients want local follow-up, so we're not going to send them to a surgical centre. Just for information, although Southampton is a modest distance away on the map, the travel time for the round trip is going to be at least 3 to 4 hours, and the likely cost of travel would be around 50 to 100 US dollars. It's much easier, we think, to do this at home. We give patients a temperature chart. We do try and persuade them to buy a decent thermometer, and a decent electronic thermometer in the UK at present will cost between $20 and $70 US. They have weekly blood tests and a transthoracic echo for the first 4 weeks of follow-up. Will ensure that they've either had adequate oral hygiene pre-treatment, or that they get proper dental follow-up. There's been a lot of talk, certainly in the United Kingdom, but I think elsewhere, about the role of prophylactic antibiotics for dental work and minor surgery in this group of patients who've had proven endocarditis. The evidence to support this remains controversial, but most cardiologists in the UK would argue this is a high-risk group at some risk of recurrence, and they should generally have endocarditis where that may be indicated. I'd just like to go over the clinical pathway again by way of summary. So you confirm the diagnosis as the first strategy, discuss this with microbiology colleagues, determine the risk of your patient, transfer them if they're high risk, keep them if you're comfortable that they're not high risk, and you can offer them guided treatment. Watch them, monitor them properly during the course of treatment, but don't be afraid to discharge them at the end of that, but monitor them afterwards. If there's any question of them doing badly in the meantime, aim to transfer them to a surgical centre. I'm very grateful to you all for your attention. I'm very happy to take any questions. Thank you.